themselves as we go along. Just to correct Cynthia's initial introduction, we are actually presenting on the Shellbrook primary health care access to the clinic. And the challenges that we found with Shellbrook is that they had the longest lead time to book an appointment of 14 days, which is the longest out of our 9 primary health care sites. So the 14 days, I just want to quantify that a little bit. It is an average of our waiting times that we collect daily from March until the end of May, and is a combined average between both the physician groups and the nurse practitioners that provide service at that clinic. So the staffing at the Shellbrook Primary Health Care Clinic has 4 physicians that provide service, as well as a nurse practitioner that's currently on maternity leave, and another physician that will be joining us in September. The one caveat as well I just want to identify is that those physicians are also responsible for providing on-call services at the hospital. The value stream map that you'll see here shows the journey pre-Kaizen of one client going through the system, and the lead time is noted as 48 hours and 49 minutes. So, like I said, the average lead time that we quoted initially was over a period of time of a couple of months. This was the journey of a particular client that was followed at the clinic on that day. So the value added time was 12 minutes and 50 seconds, of which is about 1%, or less than 1% actually, of that client's time spent with us.
Hi, my name is Vivian Campbell, and I had the privilege of being the team lead for this amazing team. I'm from Kelsey Trail as well. In terms of the TAC time, we had a TAC time of 9 minutes and 6 seconds, and which meant that in terms of the clinic hours, if we were going to meet the demand of the clinic, every 9 minutes and 6 seconds there would be a client beeping. In terms of the target progress, when we evaluated before the RPIW week, we identified that the provider was leaving the patient room searching for blood pressure equipment, and we wanted to look at walking distance for the MD. We also noted that the charts were being pulled for all of the clients and not always being used because the electronic medical record was being used in most cases. We also wanted to look at that lead time for that third next available appointment. As Connie stated, it would, for Shellbrook, was 14 days, and the regional target is 4 days. So we wanted to look at that as well.
My name is Chamberlain Andrew, and I'm one of the physicians in Shellbrook Clinic, as well as a participant, and my role there was more of process owner as well. As was mentioned before, we had a problem noticing that the physician was always moving out of the room to get equipment for assessment, such as the blood pressure cuff machine and the oxygen saturation machine. And looking at the spaghetti diagram, you can see that for over 2 hours, the physician made 210 steps, which is roughly 215 feet of movement. When we tried to get a data collection as to why this was happening, we found that it was more from having to get equipment than any other thing. Looking at the pre-Kaizen value stream mapping, we found out that each cycle time was around 15 minutes, 36 seconds, which our aim was to reduce to create effective time for the patient and the doctor, with minimal interruptions by the doctor moving in and out of the clinic. Yeah, we did entertain a lot of ideas, and one of the ideas was to get the MOAs to do a sort of pre-assessment before the patient goes into the clinic to see the doctor, with the aim to reduce the number of interruptions. Also, we also wanted to find out, develop some sort of work standard for preparing the rooms and fixing in the patients when they should come. And also there was the problem of getting a standard procedure for rooming in patients. We also wanted to assess that time as well. So post-Kaizen, after we instituted that, we noticed that there's been a reduction in the steps taken by the physician. Initially it was 200 and something, now it's down to 64 steps, which was very significant. And also comparing our cycle times, which was initially 15 minutes, was brought down to 12 minutes, 47 seconds. Comparison between the pre and the post Kaizen, we were able to decrease the cycle time from 15 minutes to 12 minutes, roughly, because of minimal disruption in the time spent between the doctor and the patient, which also improved the quality time for the patient as well. Also, we did some standard work combination, trying to compare the time it took the MOA to assess the patients. And we found out that we pre-Kaizen, we took time, the time was just around 19 seconds, but seems to have increased to 386 seconds because now the MOAs were the ones assessing the patient, taking their blood pressure, oxygen saturation, and all the rest. Here we have the time observation sheet that we timed most of the time it took for the MOA to assess. We had some sort of delay because we had to reteach, and probably some demonstrations were carried out. So it took some time, but with time they became efficient, and it took an average of 3 minutes per patient to assess. We also developed some work standard as to who should be assessed, what kind of assessment should be done, and this is part of something we've introduced in the clinic so far to help the MOAs determine who should be assessed and who should not be assessed. In terms of skill training, we've been able to train 2 of our MOAs, and they've exhibited efficiency in assessing the patients prior to the visit, and that's just about it. Thank
you. My name is Lydia France. I'm the manager for the Shellbrook Health Clinic and a participant within the RPIW for Shellbrook. I'm going to be covering 3 pieces of work, starting with the pulling chart piece that was referenced earlier. So previously, we up to the RPIW were pulling all of the charts, even though we were using an EMR. And so the idea was that we needed to look at traveling not pulling the charts. And on average, they receive 25 patients per day. And it amounts to, it's 3 minutes and 5 seconds cycle time in order to pull those charts to get them back to them. And which amounts to about 76 minutes a day. So what we tried was for 3 days not pulling the charts and at all unless the physician actually queued to have the chart pulled. And the results were, over 3 days we pulled 1 chart for a total of 3 minutes, saving well over 73 minutes a day in travel time as well as time spent by the MOAs used for other things as well. The next piece, so we created the work standard to ensure that both the physicians as well as the MOAs were clear in terms of how the queue for that chart to come in and to make sure that it was taken right to the exam room when needed. And the multi-skills piece we'll address at the end of the 3 projects. So the next piece was advancing patient status. So the problem was patient flow in and out of the exam rooms were not consistent. The physicians didn't always know when the exam room or the patient was ready in the exam room, and the MOA didn't always know when the patient was gone to get it ready for the next one. So it was decided we needed a visual cue in order to indicate patient's status of where they were in terms of flow. Within the EMR, there's an advanced status functionality, which had been used, or users had been trained at the beginning of the EMR implementation, And what we found, it wasn't being used consistently, so what we did was create work standards for both the MOAs as well as for the physicians and the providers to ensure that they were using the advanced status and that at any given point in time, either of them could pinpoint where the patient was at. In the work standard, what we did was ensure that for the training that was emphasized the importance of consistent use to ensure effective flow in and out of the rooms. The third piece had to do with clinicians batching follow-up work, the not indirect care till the end of the day, phone calls from the hospital, long-term care, whatever, refills, etc. What we decided, what we found was that each provider has 2 exam rooms, and they're usually side by side. And then in between seeing patients in those 2 exam rooms, which are close, they were walking back to the T room, which is a fair distance. So the idea was that we would turn the second exam room into a flow station where the physician would move into that flow station, and that we then also worked on identifying key pieces of work that needed to go to that flow station that the physician could work on in between and get done while waiting for the next patient. These priority tasks included those items that needed to be done between 1 and 3 hours and needed fairly immediate attention. And that we also required that they be brought to the flow station in writing with clear direction on the patient condition as well as in terms of the contact information for them to call them back. The results what we saw was that the patient ended up with extended travel time, far more so than what they were traveling beforehand. And that was as a result of there's only 1 exam room available, and so consequently they were being placed elsewhere and then brought to the exam room. The other, in terms of physician feedback, was that they were waiting for the next patient. It wasn't as efficient as having 2 exam rooms, and that there wasn't enough flow station tasks to use all of their time while they were waiting in between. In terms of the MOAs, it increased significantly the travel time in terms of moving patients from one exam room to another one. So what we learned from this was that we wanted to move back to having 2 exam rooms. It creates better flow for physicians and the providers. But we also want to continue the flow task concept and the standard work that was created in terms of what would go to the providers in between patient visits and what needed to be attended to, and that would be done back in the team room where they originally started. The other additional results, positive result that came out of this is that there was a fairly significant conversation about what urgent tasks were and when to pull the physician out of the exam room and how to do that, and that's clear in terms of both the providers as well as the MOAs now. In terms of the multi-skills training, we've made some significant gains in terms of making sure people were trained and are ready to go on all 3 areas.
Hi, I'm Chris Donahue. I'm the patient participant. We identified that the loss of time when looking or gathering the equipment needed for specific procedures. So we built 5 different kits for specific procedures. They were itemized and bagged and labeled and placed in the bedroom for easy access for the MOAs, which allowed them to keep the patient flow moving at a faster pace.
Hi, I'm Sam Moritz, and I'm part of RPIW 23, and I'm a participant. So we 5S the bedroom, and we actually did 3 projects: the bedroom, the bulletin board, and a bookcase in the team office. So pre-Kaizen, the bedroom was pretty cluttered and disorganized. When the inventory was done, there was well over 3,000 items counted. And so there's an example of that. Then our pre-Kaizen score was 1.1. So I did a summary sheet of moving the bookshelf for the educational materials, and Dr. handouts was to move that shelf to the team office. So then we did move that. There's another show of the bookshelf that was moved pre-Kaizen. So there it is post-Kaizen. We moved it to the team office and we labeled everything and it gets a little disorganized at times. So there, post Kaizen, we have it labeled to condition, and we have it faced nicely, so they don't have to root around for what they're looking for. We also organize their syringes and needles and other items and label the shelves and bins it all so that it's easier for them to get at. We put their life-saving equipment all on one wall, and it's more accessible for them also, so they can get at it.
Good afternoon. Good afternoon, I'm Johan Huson. I'm one of the managers in IT and a participant of this RPIW. So following what Sam mentioned earlier about labeling, organizing the medroom, we created a tag or a signal to the MOAs or medical office assistants to let them know when to check how many stock is there and when to order the next supply. So we created a standard work. It's an orange tag, and we created a work standard to make sure that new system in place is reinforced and everyone is trained for that. We also created a pre-filled purchase request form so that the MOAs will not have to rewrite everything. They just have to tick the quantity on the purchase request form and send it to materials manager. We also put visuals inside the medroom to give to show the staff what the medroom should look like in normal condition. So we did train all the MOAs, and next please. And then the one on the screen right now is a sample of the list that we have returned. We returned over 500 supplies, or disposed 500 supplies. So another idea that we've done is to, the medroom is always open, and so we put a sign on the door, as well as putting a spring on the door to make sure that the door is closed by itself and it's not open. So this is a picture of the sign on the board. Another idea that we have implemented is to make sure that the bulletin board is categorized and it's not cluttered with different types of information. So this is the new board now. It's very organized and people can see the proper information that we have. In conclusion, for 5S, we increased space with 4%, and for inventory we reduced 14%. And from 1.1 we have a 3.0, which is 76% improvement on our 5S.
Thank you. My name is Connie Lee. I'm the Director of Primary Healthcare, and I forgot to introduce myself the first time around. The last two projects that we were able to trial was phone appointments to clients and to extend our clinic appointments through to 5 o'clock. So the first one, our phone appointments, the primary focus of that was both to increase access at the clinic, so expand capacity directly, and to make a service that was a bit more patient-friendly as far as people not having to travel or not having to take off time from work. So I think that was a huge advantage. We found that phone appointment took on average around 8 minutes. That included both the call and the required documentation. We developed standard work that outlined the criteria required for the patients that would be suitable for that kind of a visit, and then completed our work standard and completed the training. The second project around extending appointments to the end of the day was we changed our clinic schedule so that our follow-up time was more interdispersed throughout the day, and appointments were available right until 5 o'clock for clients that either have to work or in school or something like that. That was the extent of the projects. Some of the other items, just to wrap up, we did the waste wheel. We were able to address 11 items out of the 24 identified areas of waste, specifically, or most waste that was mostly in parts traveled or inventory. And the newspaper items, we brought forward 22 items on the newspaper, of which we addressed 14. So there's a few outstanding. Thank you.
terms of the target sheet, you've heard the story already and the improvements that were made. We eliminated the walking time for the MD to go searching for the assessment equipment. And also the charts traveled, one chart was pulled instead of 25 for today's patients. In terms of the workshop summary, it was a great success with an awesome team, I have to say. The 5S, you saw the success of that. We developed 9 work standards with training well on the way, mostly completed. We had some awesome team meetings as well. There was great collaboration with this team, and I know that that's something that they will keep going as well. I was so impressed with the staff's willingness just to try things. You know, even if they had questions about its success, they were willing to try and implement. Everyone learned, everyone contributed, and that led to the success of the team. I want to say some huge thank yous. This was just an awesome team to work with, and thank you so much. Thank you to our patient rep, Chris. She did an awesome job of representing patients. And thank you to the Shellbrook Primary Healthcare Clinic. They were just a great team to work with. Our sponsor was always there when we needed her. Thank you, Linda. And certainly our process owner, Dr. Chamberlain, he did double duty. He was not only the process owner, but he was willing to participate for the week as well. And so that was great. Thanks to the KPO and our JVA consultant as well, and the support team that supported all the work that was done. Thank you very much.